we have Dr. Ria Sara Abraham, Assistant Professor, Department of Anaesthesia, taking us through the topic, Alternatives to Thoracic Epidural, Regional Blocks for Major Abdominal Surgeries. Because in anesthesia, there is always more than one way to get the job done, and we are constantly looking for better ones. And to keep things precise and on point, we have our moderators, Dr. Apranjit Paul, Professor, Department of Anaesthesia, and Dr. Noble Cherian, Assistant Professor, Department of Anaesthesia. May I request you all to kindly take the stage.
I'm Ria. I'm an Assistant Professor here at Department of Anaesthesia in CMC Vellore. I understand this is the last session, so I promise I'll keep it brief and hopefully relevant. So if you guys were here for the panel discussion, you would have seen that at the time of the discussion of the epidural, whether how relevant it is, there was quite a stir at that time. So I hope we'll be able to clear that by the end of this talk. So we're going to be looking very briefly at the overview of pain pathways just to understand the significance of treating visceral pain. We're going to look at what has happened to thoracic epidural over the last 2 decades and why there is a need for alternative regional anesthetic techniques and how to go about choosing the most appropriate modality. So postoperative abdominal pain has its origin primarily from the somatic or the incisional part. There's also a visceral component to it and a referred pain from the visceral organ. So while all of our analgesic modalities address the somatic pain, visceral component often remains unaddressed. And so in contrast to the somatic pain, visceral pain is mainly, it's diffuse and poorly localized. And in an anesthetized patient, it always only presents as an autonomic response. So why is it important, is it important to treat visceral pain at all? So in 2001, the Journal of Pain, actually, it published an article which showed the predictors of early pain following laparoscopic cholecystectomy. And they concluded that the primary target of analgesia following any surgery should be the somatic pain. However, if the patient does complain of symptoms that resemble a visceral pain, then one should consider that as a warning sign for that patient to develop chronic post-surgical pain, and then it should be addressed from then on. So the autonomic nervous system is the main transmission pathway that is responsible for the transmission of visceral pain. Also, the receptors and the other pathways are quite complex, and they intermingle with a lot of the somatic pain pathways, and they are very distinct to these visceral pain. So the components of enhanced recovery after a major abdominal surgery from the anesthetic perspective are essentially an effective pain relief, early mobilization, and early recovery of the gastrointestinal function. So if we were to look at a timeline of evidence, probably it was around the early 2000s when the use of ultrasound-guided regional anesthesia became popular in abdominal surgeries. Around the same time is when the ERAS guidelines were published for colorectal surgery. So around after 2010 onwards, we have started around 2000, since then we have started implementing some of the ERAS protocols in our anesthetic practice as well. So over the last decade, because of these two factors, is where we have seen a decline of thoracic epidural as a primary modality for abdominal surgeries. So it probably started with this major audit. So this was conducted by the Royal College of Anaesthetists across all of the hospitals under NHS, where they made an audit for major complications following central neuraxial blocks. So here they were not really specific about abdominal surgeries. They included all surgeries, lower limb, abdominal, all surgeries. And they saw that, so the major complications that they looked at were epidural or spinal hematomas, meningitis, wrong route administration, and cardiovascular collapse, or hypertension requiring vasopressor support. So they saw that a lot of the complications were with epidurals and combined spinal epidurals, and a lot of them were either directly or indirectly related to the neuraxial block. So fast forward to 2014, when people started debating the role of epidural analgesia in abdominal surgery. So these authors concluded that in patients with, they were actually supportive of the epidural. So they concluded that there is a level 1 evidence of beneficial effects of the epidural, specifically in terms of reduction of pulmonary, cardiovascular, thromboembolic complications, and also in the incidence of ILS and the reduced requirement of NSAIDs and opioids. Then there was again an article that was published in a surgery journal, which said that epidural is not the gold standard anymore because of the shift towards laparoscopic surgery. But however, they did state that in patients with severe pulmonary disease, epidural still proves to be of immense benefit. So following that, in 2023, the anesthetic community, at least some of us, got very defensive about the epidural, and they said that, so this article specifically says that the high thoracic epidural is the most complete regional analgesic technique, and it does not compare to any of the other regional analgesia techniques that are there. However, it does require training to master, and it requires a good acute pain service team to follow up. And they also mentioned that the side effects that actually occur with an epidural, like hypotension or urinary retention or delayed mobilization, can actually be combated with appropriate dosing strategies. So finally, I'll just come to this article. So this was published in the British Journal of Surgery, where they have also concluded that peripheral regional techniques are replacing epidural anesthesia. However, in patients at high risk of chronic or postoperative pain, the epidural remains the gold standard. So, having spoken about all of that, what is the need for alternatives to neuraxial analgesia? It, I think, primarily boils down to these 4 points. There is a shift towards laparoscopic and robotic surgeries, higher failure rates of thoracic epidurals as compared to lumbar epidurals. There is incidence of hypertension where some patients do require vasopressor support as well as fluid resuscitation. And there is a risk of coagulopathy, specifically in liver resection surgeries. So these are the points which have actually behaved as major distracting factors from using an epidural for all major abdominal surgeries. So what are the alternatives that we have at hand? All right, so if we were to look at it from proximal to distal, for all the postgraduates in the house, this is an image of a typical thoracoabdominal spinal nerve arising from the spinal cord there. You have the dorsal ramus that exits here, and then you have the ventral ramus going forward, gives off the lateral cutaneous branch with its posterior and anterior divisions, and then it terminates into the anterior cutaneous branches. So where all can we block, where all are regional blocks applicable in this area? You have the paravertebral, the erectus spinae, the quadratus lumborum block, the various approaches to TAP block, as well as the rectus sheath block, and a fairly new block, which is the external oblique intercostal plane block. So starting with the thoracic paravertebral block, the paravertebral space is a wedge-shaped space that is next to it is bounded medially by the vertebral body, laterally by the intercostal space, anteriorly by the endothoracic fascia and the parietal pleura, and posteriorly by the costotransverse ligament. So so you can block it using the transverse approach or the paramedian sagittal approach. And what we are trying to look at is the paravertebral space in between the intertransverse processes, and we are trying to deposit drug in between, deep to the costotransverse ligament. So this is the performance of a paravertebral block that we had done 2 days back in a 2-year-old child who was posted for an open pyeloplasty. Look, angle down more.
1, 2, 3, 4, 5.
Sorry, angle down. So this is the spinous process, this is the transverse process, and here's the needle coming through, and this is the pleura. So here you can see the pleural dipping because of the local anesthetic that has been deposited deep to the costotransverse ligament. Yeah. So this is the image that we got following the block, where you can see this is the pleura, the transverse processes, and you see the drug that is spread on the posterior aspect of the pleura. So what are these paravertebral by proxy blocks? So they had postulated that, so there was this article that came out in 2018 which postulated that is it absolutely essential to enter the paravertebral space to get an adequate block? So they probably said that no, it's not really required to enter the paravertebral space. So they said that it's probably enough to just be around the paravertebral space. So you have this, which is the paraspinal or the intercostal block, which is above the paravertebral space between the erector spinae muscle and the external intercostal muscle. Then you have the erector spinae plane block. Then you have the the retrolaminar block and the midpoint from transverse process to pleura block. So what these authors suggested is that if the drug is deposited at any of these locations, they would seep into the paravertebral space and act by proxy. So, however, it still remains unclear whether these alternative blocks would block the sympathetic chain. So, while the paravertebral block would block the sympathetic chain, these other blocks may or may not. So these are the, I'm not going to go into this slide. These are basically the needle injection and the insertion points for all of these blocks. Although I will highlight on this point that there are no randomized control trials that prove its efficacy to a paravertebral block. So how do we, when do we use a paravertebral block? Mostly for unilateral thoracotomies, pyeloplasties, nephrectomies, rib fractures, as well as an open cholecystectomy. Can use either the linear probe or a curvilinear probe, preferably the linear probe if the build is, if it's a thin build patient. So usually we can get to cover around 4 to 6 dermatomes with a paravertebral block with a volume of around 10 to 15 ml. There are complications which can include the epidural spread. It can have a pleural puncture, or it can even spread to the contralateral paravertebral space. So moving to the thoracic erector spinae block, like we mentioned, it is another paravertebral by proxy block, where they have said that, so we usually perform in paramedian sagittal, and the needle is supposed to enter, hit the transverse process and lift the erector spinae muscle of the transverse process. So the erector spinae muscle plane block was introduced in 2016, and ever since then there have been more than 200 articles that have actually 200 studies regarding the erector spinae plane block. So over all of these studies, the one thing that was common is that a lot of inconsistencies were there in the performance and the post-op analgesia with erector spinae plane blocks. So in 2023, some authors postulated that the traditional erector spinae plane block, where you are actually going over the transverse process and lifting the erector spinae muscle off the transverse process, is actually going to block only the dorsal ramus of the nerve. So you see here, if this is where you deposit the drug, only this bit of the nerve is actually getting anesthetized. So this is very suitable for spine surgeries, and only for spine surgeries, because it will give you a very patchy block of only the posterior thoracic wall. Whereas what they said is, if you want blockade of the lateral as well as the anterolateral thoracoabdominal wall, you need to go beyond the erector spinae. So I'll just go back here. Yeah, you need to go beyond the transverse process and hit the midpoint of the transverse process, such that there is paravertebral spread as well. So in around the same time, the American Society of Regional Anesthesia, European Society, as well as the Canadian Society of Regional Anesthesia, they confirmed that the erector spinae is a superficial block, which makes it more, which makes it a better alternative than probably the paravertebral and the epidural for patients in whom we may expect a risk of bleeding. So indications stay the same, are almost similar to that of a paravertebral block. But the volume used is significantly higher because the erector spinae fascia is over a much larger area. So the drug volume that we probably use is around 20 to 30 ml. So if we were to compare the three blocks, that is the epidural, paravertebral and erector spinae plane block, we've already spoken about the volume required for each block. Sympatholysis is achieved only with the thoracic epidural and the paravertebral. Performance of procedure, yes, the epidural, we are not used to a lot of ultrasound scanning while performing an epidural. So yes, it requires a higher learning curve, but the paravertebral probably needs the most skill when it comes to using of ultrasound. And the erector spinae plane block also requires skill, but then again, like I said, there's a lot of inconsistency with it. Bleeding risks, yes, epidurals and paravertebrals are not recommended. Whereas erector spinae, because they have been confirmed as a superficial block, they can still be more suitable than the other two. Alright, so the quadratus lumborum block is actually, it has various approaches. So all of the approaches are basically are directed at which aspect of the muscle is the drug injected at. So this image is basically showing the placement of the probe between the costal margin and the iliac crest, and this is what you see. So this is a longitudinal view of all the muscles with the needle insertion coming in between the QL and the psoas major. So if I have to show you here, it's between the QL and the psoas major here. So this is actually an anterior QL block. So if we have to understand the quadratus lumborum block, it is important to know the anatomy of the thoracolumbar fascia. So thoracolumbar fascia is mainly basically a strong fascia of the that covers the muscles of the posterior trunk, and it has three layers. So it has the posterior layer which covers the erector spinae muscle, the middle layer which is between the erector spinae and the quadratus lumborum muscle, and the anterior layer which is in front of the quadratus lumborum muscle. So one interesting thing about the thoracolumbar fascia is that it goes, so as it moves cranially, it actually becomes continuous with the endothoracic fascia of the thorax. So as I said when I was explaining the anatomy of the paravertebral space, the paravertebral space is bound anteriorly by the endothoracic fascia. So theoretically, the QL block, theoretically the QL block can actually spread through the thoracolumbar fascia into the endothoracic fascia into the paravertebral space. So if you keep that in mind, you would expect a dermatomal coverage of T4 to L1. However, clinically that is not very often what we see because that would require a definitely much larger volume. So this is again a sonor anatomy showing the QL block in the transverse view. You see the vertebral body, the transverse process, the quadratus lumborum muscle, the erector spinae posterior to the transverse process, and the psoas major anteriorly. So this is the shamrock sign that we see. And the three approaches to the QL block. So that is, QL1 is basically the lateral QL, where you deposit the drug lateral to the QL muscle. QL2 is posterior QL, that is the drug is deposited between the QL and the erector spinae, and QL3 is the anterior QL, between the psoas major and the QL muscle. So indications are again nephrectomy for obstetric gynecological surgeries for iliac crest bone grafts. Coverage, like I said, T4 to L1 is a bit of an it would be a stretch to think that it would cover T4 to L1, but we can get a coverage of T9 to L1, T8 to T9 to L1. We use the curvilinear probes with a volume of 20 to 30 ml. So the complications with it can be a renal injury or a peritoneal puncture. So now coming to the transverse abdominal plane block, which is probably the most used block in abdominal surgeries. So this one, it has various approaches. So the subcostal approach, that is the figure A, it is just beneath the subcostal margin as medially and cranially as possible. The lateral tap is actually along the mid-axillary line. The anterior tap is medial to the anterior superior iliac spine, and the posterior tap is, so for the posterior tap you basically place the probe at the mid-axillary line and you go as posteriorly till the posterior most end of the transverse abdominis transverse abdominis muscle. And here you can see that the drug is deposited between the internal oblique muscle and the transverse abdominis muscles. So indications are lower abdominal incisions, mini laparotomy, cesarean sections, or inguinal hernia repairs. Coverage is usually T11 to L1. Using a linear probe, we deposit usually 15 to 25 ml on each side. So this is a slide comparing the 3 QL blocks and the 3 approaches to the TAB block. So one thing that I would like to bring to your notice here is the QL1. So the QL1 I said was the lateral TAB. So the QL1 is actually very similar to the posterior TAB block because it's at the same edge. So where the transverse abdominal muscle ends is where the QL muscle also ends. So they both meet. I'll just go back to this slide. Yeah, so this is the transverse abdominis muscle and this is the QL muscle. So here, if once you deposit drug here, it would actually seep through this fascia and also act as the posterior TAB block. So the coverage that you would expect with both those blocks is around T12 to L1. Visceral effects, none with any of the TAB approaches. QL1 block will not give you a visceral effect. However, QL2 and QL3, like I said, in theory, because it may spread to the paravertebral space, they say that yes, theoretically it can give, but there is no real way to prove whether a visceral analgesia is actually obtained. Performance of procedure, all of them require an ultrasound skill, and bleeding risks, yes, they can be used. However, the QL3, because it's a transmuscular block, can cause a QL hematoma. The external oblique intercostal plane block is a relatively new block. So this was targeted at actually upper abdominal and liver surgeries where you have a rooftop incision or the reverse L incision. So this here the drug injection is actually targeted between the external oblique muscle and the intercostal muscle around the 6th to 7th rib. So what this actually targets to do is, so there's the needle insertion point is around the mid-clavicular line, and you're targeting drug spread, and the target drug spread actually covers up till the lateral thoracic wall and thus blocking the anterior cutaneous nerves as well as the lateral cutaneous nerves. So indications for this, like I mentioned, are for liver surgeries or subcostal incisions. Coverage is usually expected between T6 to T11, and the volume that we use are around 15 to 25 ml. So this is the last one. So the rectus sheath block. Rectus sheath block is mainly for midline incisions of laparotomies. So the rectus sheath covers only the anterior cutaneous nerves. So where we give the rectus, so this is an image of the rectus abdominis muscle with the posterior rectus sheath and the anterior rectus sheath. So drug injection is actually between the rectus muscle and the posterior rectus sheath. So why is that important? So above the umbilicus, the rectus muscle, the rectus muscle has an anterior sheath and a posterior sheath. Above the umbilicus, if you can see this, you have the anterior sheath here, you have the posterior sheath here, and the drug is actually deposited beneath the rectus muscle. Now below the arcuate line is basically where the transition happens, because the posterior rectus sheath is not posterior anymore. So the posterior rectus sheath is basically formed by the transverse abdominis, the fascia of the transverse abdominis muscle. So this fascia, it actually moves over the rectus abdominis muscle and it becomes anterior below the arcuate line. So we should realize that below the midpoint between the umbilicus and the pubic symphysis, the posterior rectus sheath is actually deficient, it's absent. That's why the rectus block will actually cover only around T10 to T12. It will not cover beyond that. So if it's a very lower midline incision, like if it's beyond or a cesarean incision, the rectus sheath block will not cover it because the posterior rectus sheath is actually deficient below the arcuate line. The volume that we use is again 15 to 20 ml on each side with, so like I said, it's not suitable for lower abdominal incisions. Complications can be a peritoneal breach or a rectus hematoma. So this is the last slide that is comparing the last three blocks that I mentioned. So the subcostal tap, external oblique intercostal, and the rectus sheath block, all of these are blocks that are targeted at the upper to mid-abdomen regions. And the subcostal tap, like you can see, the area of coverage is this. The external oblique intercostal plane actually seems to have quite a large area of coverage, whereas the rectus sheath block has a primarily periumbilical area of coverage. There is no visceral effect with either of the three blocks, and performance of procedure is also relatively safe if you have a decent ultrasound skill. So the take-home points are actually that thoracic epidural may in fact be losing popularity as the gold standard anymore for abdominal surgeries. So what we have to do is to understand the targets of analgesia for any abdominal surgery and look at appropriate regional techniques or a thoracic epidural if that is indicated. So finally, what we need to decide, what we need to know to make a decision is that we need to have a good risk-benefit assessment, and safety and enhanced recovery has to be the priority while choosing any mode of analgesia. Thank you.
Thank you, Riya. That was a good presentation. I just have one question. In your presentation, you have said that epidural is becoming less famous because of increased incidence of laparoscopy. Is it? That's one thing you said. And one more thing, I have a question. You have said that with epidural you have a sympatholytic effect, but with other things you don't have. So how do you manage that when you use other modes of analgesia?
Yes, sir. So to answer the first question, yes, for laparoscopic or robotic surgeries, we actually do not need to put an epidural anymore. For the second part of your question, yes, the epidural does provide a sympathetic because it blocks the sympathetic trunk as well. So epidurals and paravertebrals do block the sympathetic trunks, but like a lot of evidence shows that we don't need, so the somatic pain is actually what is to be addressed primarily. So if the patient develops, so in intraoperatively, we can address the pain. But once in the post-op period, if the patient has something that resembles a visceral pain, then it has to be addressed. So most likely, it is the somatic pain that the patient presents with. So once we address that, that actually takes care of most of the analgesia.
Okay. Intraop
So if we have a good analgesic modality that has been instituted preoperatively, that should take care of the intraop sympathetic response as well. So with terms of analgesia, I mean, if our analgesia is inadequate, if our analgesia is inadequate, then we may have to look at, but then we probably can look at more intravenous options of analgesics.
Okay.
Yeah, and despite that, if we are having a hemodynamic instability, then probably GTN, but otherwise it would not be first line.
Okay.
What is the experience here in our center with these blocks? And also about catheter placement. Can we place catheters, continuous blocks?
So in our center, we have mostly placed catheters for thoracic paravertebral and erector spinase. We have actually used it mainly for rib fractures. I'm not very, and plus, yeah, for catheter placement for paravertebrals, we've actually not used much of it for abdominal surgeries. But in pediatrics, we have used a lot of, we do use thoracic paravertebrals routinely for open pyeloplasties and open nephrectomies. With regards to the other blocks, QL blocks, again, we use mainly for iliac crest bone grafts, not so much for abdominal surgeries. There was a study that was done in our institute which was the use of QL block for bilateral QL block for post-cesarean section, which it was compared with an intrathecal morphine. But that study, actually, they found that the intrathecal morphine was the better analgesic. Yeah.
I think we were using...
and also in liver surgeries, we've been using, since the last, I think, 1 year, we've been using the external oblique intercostal plane block quite a bit. For more than around 20-25 patients, we've used it with catheter placements. And they've been actually shown to be quite beneficial. Patients have been mobilized very early in the postoperative period, and there have been no complications as such.
Any other questions?
Can I just add a few points? All these blocks, whatever she said, we can insert catheter. Most of the blocks we place the catheters for post-op analgesia as well. QL, it is effective for visceral pain also, the posterior one. We have done for most of the cancer pain patients. We have kept the catheter inside and given local through it for 2-3 days. It is effective, it covers the visceral pain. Okay. As far as my experience is concerned.
What volume, ma'am?
30 ml, 25 to 30 ml.
All right.
That is when it spreads into the paravertebral space,
Right,
and it relieves the sympathetic pain.
Right.
It is effective. Yeah.
And this QL, what sensory level do you get, ma'am, when you place that?
No, it's basically we give QL for lower abdominal pain.
Abdomen.
Yes,
Okay.
not for the upper abdomen, below the umbilicus, and for mainly the stoma closures, unilateral, that is found to be effective, even for postoperative pain. We leave a catheter. Yes, we can achieve till T8, but then you need to give really volumes for the
Yes,
plain
yes.
block. That matters. You calculate your maximum dose and you can give place a catheter, and it definitely helps visceral pain. Intraoperative visceral pain we address with opioids. That's what helps.
Any more questions, please?
Thank you.
Thank you, Dr. Ria, for that excellent session. Clearly, when it comes to analgesia, we have more tools in our hands than ever before. I request Dr. Aparanjit to kindly hand over the memento to Dr. Ria.
எனக்கு browser open பண்ண இதில்